Hi, everyone. Welcome to our SciSet webinar. We are very excited. We have a highly distinguished guest speaker today to present really exciting work about American Indian cancer control and health equity. Before we go into that, just for folks who are new to this webinar, a little background about SciSet. This partnership was initiated as a collaboration between the Duke Cancer Institute, UNC Lineberger Comprehensive Cancer Center, and the Wake Forest School of Medicine. It's really a collaboration between the three community outreach and engagement programs in each of those comprehensive cancer centers, designed to better understand and address the cancer health needs in the American Indian communities in North Carolina, across the southeastern US, and hopefully build collaborations beyond that geographic region. We do activities such as these webinars. We do community events, outreach and education in various tribal communities and events to promote cancer health awareness and access to screening and screening related information. And we do research projects as well, designed to better understand the epidemiology and health related needs in the American Indian community. So thanks for joining us. As Tim mentioned, we have these webinars that occur 3 times a year, and we hope you can join us for the upcoming ones as well. So for today, we are very excited to have Professor Don Warne. He is from the Oglala Lakota tribe and serves as the co-director of the Center for Indigenous Health. And he is a professor at the Bloomberg School of Public Health at the Johns Hopkins University, and also serves as the Provost Fellow for Indigenous Health Policy. Dr. Warne is a senior policy advisor to the Great Plains Tribal Leaders Health Board in Rapid City, South Dakota, where he was recently a faculty member before moving to Johns Hopkins. Dr. Warne received his MD from Stanford University School of Medicine in 1995, his MPH from Harvard in 2002, and his extensive work experience includes working as a primary care physician at the Gila River Healthcare Corporation in Arizona, staff clinician at the NIH, Indian Legal Program faculty with the Sandra Day O'Connor College of Law at Arizona State, and many more experiences. We're really delighted to have him here and look forward to the exciting presentation. So as Tim mentioned, there will be a few questions throughout. So just as a test, if you all have your cell phones or computers, log on to polev.com/UNCLCN, and if folks could answer this question as a trial, we'll know that folks are set up before we move on. So we'll give it maybe 30 seconds. Okay, so our disclosures are listed here, and our speaker has no relevant financial disclosures today. Oh, sorry. Okay, well, great. I think we're off to a great start. So, Dr. Warne, please go ahead.
Well, thank you so much. Yeah, a very good start. 100% correct on the initial question. So good for continuing medical education. Well, again, my name is Dr. Donald Warne, and I'm just so pleased and honored to be here. As you may know, November is Native American Recognition Month. So very pleased that here at the last day of November, we're at least addressing some very important issues, looking at cancer control and health equity in the American Indian population. And as was mentioned, I am a primary care physician, but also work in research and academics, and very pleased to now be with the Center for Indigenous Health at Johns Hopkins. Just for a brief overview of our center, it was the Center for American Indian Health for about 30 years. And we just recently changed the name because much of the work is now moving internationally. Excuse me. Sorry about that. So the way the center started is in the early 1990s, there was an outbreak of diarrheal illnesses in one of the reservations in Arizona. And unfortunately, many of the babies and young children were dying from dehydration. So a team from Johns Hopkins went out to that particular community to develop an oral rehydration solution. And that eventually became Pedialyte. So Pedialyte actually was originated out of that work between Johns Hopkins and one of the tribes in Arizona. And then the work has expanded tremendously over the last 3 decades. And we're doing work related to chronic disease, infectious disease, mental health, and maternal and child health. And one of my roles is to expand the work into the policy arena. I think it's an important starting point just to look at the nomenclature and what is the terminology that we use to describe our population. So I'm sure we've heard the term American Indian and Alaska Native, and that is the term used to describe the race. And the races in the United States are, for some reason, defined by the OMB, Office of Management and Budget. And there are several races that are recognized. Of course, American Indian, Alaska Native, Caucasian or white, Black or African American, Asian American, and Pacific Islander. And then there's one ethnicity that's recognized, that's Hispanic. So people are either Hispanic or non-Hispanic. So that's why we hear the term non-Hispanic white, for example. So the term American Indian and Alaska Native is legally defined as the U.S. Indigenous peoples in North America. So the American Indian population in the lower 48 states is very diverse. There's hundreds of tribes, lots of different languages and cultures. And then in Alaska, there's also a lot of diversity. Some of the people who are indigenous to Alaska culturally are American Indian. And those would be the Athabascan group in central Alaska. So Athabascans are all over North America, and they are related to the Navajo and Apache tribes in Arizona, for example. And there's Athabascans across Canada. But the Inuit populations and the Yupik populations in Alaska are not American Indian. They're more of a circumpolar culture. So there's Inuits, for example, in Siberia, as well as Alaska, Canada, and Greenland. So if you go to Alaska and you call them American Indian, they'll be very offended because they are not American Indian. So that's why we have the term American Indian and Alaska Native. So we also hear the term Native American used interchangeably, but we'll see how that is slightly differently defined. Within the American Indian and Alaska Native population, we have what are enrolled tribal members. So the racial designation is self-defined on the census. So we self-designate what race we are. But an enrolled tribal member is someone who is recognized by their tribe as a citizen of that tribal nation. So we now have 574 federally recognized tribes in the United States. And each of the tribes has their own process for enrolling its members. So as an American Indian myself, I am actually, in many ways, I have tri-citizenship. I'm a citizen of the United States, I'm a citizen of my tribal nation, and a resident of the state in which I live. So as a result of that, we have access to various types of health services. As a citizen of the U.S., if I were old enough for Medicare, I'd qualify for that and could use that. As an enrolled tribal member, I'm eligible for Indian Health Service. As a resident of a state, if my income was lower, I would be able to enroll in Medicaid, for example. So we have a lot of American Indians and Alaska Natives who use multiple health systems, which really does complicate data collection. So not all American Indians and Alaska Natives use the Indian Health Service. I think it's an important point to consider. In the last census, there were over 9 million self-identified American Indians and Alaska Natives. And there's far less than half of that are actually enrolled tribal members. So it's an important thing to keep in mind in terms of the terminology that we're using. So again, we do see the term Native American used interchangeably with American Indian, but the term Native American is also legally defined. So Native Americans, based on the Native American Programs Act in 1978, defined the Native American population as American Indians and Alaska Natives, but also Native Hawaiians and indigenous peoples to the U.S. Pacific Islands. So the American Samoan population is Native American. The Chamorro indigenous peoples in Guam are Native American from a legally defined perspective. So if we're saying Native American, we have to be cognizant that we're including indigenous peoples of the Pacific Islands. So for myself, I describe myself as American Indian because I'm not Alaska Native, even though on the census I have to check the box American Indian and Alaska Native. I am Native American, but I usually don't use that term because typically the populations I work with are the tribal populations. So just important to keep those things in mind. I've heard a lot of discussion about, there are many people who don't like the term American Indian because the roots of that is actually from Columbus. He thought he was in India, which is why we have American Indians. We have an Indian Health Service and a Bureau of Indian Affairs, and I'm an American Indian because essentially he was lost at sea and thought he was in India. So a lot of people don't like that term. But even the term American, if we look at the roots of where that word comes from, it's from Amerigo Vespucci, who was another Italian explorer. So I would like to point out that if we're having the argument or discussion about which term is better, American Indian or Native American, in many ways, we're having a discussion about which Italian do we want to pay homage to, Columbus or Vespucci, essentially. So the term that I prefer is indigenous, and it's much more encompassing. So the indigenous peoples are the original inhabitants of various parts of the earth. So the indigenous peoples of the lower 48 states, including North Carolina, are the American Indian peoples and population. But we have indigenous peoples worldwide. And as I had mentioned, through our center, we're now the Center for Indigenous Health. And one of the things that we observe internationally is that there's a very similar pattern of health disparities that we see among indigenous peoples, whether they're indigenous to Canada, the US, Australia, New Zealand, or Pacific Islands, or other parts of the earth. We tend to see very similar patterns of health disparities, including cancer disparities. So if we look at changes to food systems and dramatic changes to diet and lifestyle, we see many of the lifestyle-related chronic diseases, including diabetes, heart disease, and some forms of cancer, are at higher rates among indigenous peoples because of those tremendous changes as a result of colonization. So I would like to do a land acknowledgement. I just was working at University of North Dakota for quite a number of years and just recently transitioned to Johns Hopkins, but this is my homeland, is in the Dakotas. And just very briefly, the land acknowledgement states that today the University of North Dakota rests on the ancestral lands of the Pembina and Red Lake bands of Ojibwe and the Dakota Oyate, presently existing as composite parts of the Red Lake, Turtle Mountain, White Earth bands, and the Dakota tribes of Minnesota and North Dakota. We acknowledge the people who resided here for generations and recognize that the spirit of the Ojibwe and Oyate people permeates this land. As a university community, we will continue to build upon our relations with the First Nations of the state of North Dakota, the Mandan, Hidatsa, and Arikara Nation, Sisseton, Wahpeton, Oyate Nation, Spirit Lake Nation, Standing Rock Sioux Tribe, and Turtle Mountain Band of Chippewa Indians. And I know many universities now have land acknowledgements and are formally acknowledging the indigenous peoples that resided in their communities long before there was colonization. So very proud of the University of North Dakota for doing that. Here at Johns Hopkins, the School of Nursing has a land acknowledgement, but not yet public health. So that's one of the things that we're working on. Just to give you a feel for where I'm from, I'm actually from the Oglala tribe right here in southwestern South Dakota. The red dot is where Rapid City, South Dakota is located. University of North Dakota is way on the northeastern part of the state of North Dakota. And one thing that a lot of people don't realize is that Dakota is a tribe, the Dakota people. So the reason this is North Dakota and South Dakota is that this is the homeland of the Dakota peoples historically. So there's 9 tribes in South Dakota and 4 tribes in North Dakota. and a real significant American Indian population where I'm from originally. Now, the reason it was called the Dakota Territory is that the Dakotas were further east and colonization came from the east. So as the westward expansion was occurring, the colonizers encountered the Dakotas first. So that's why this became North Dakota and South Dakota. So I always like to point out that if colonization had come from the west, this would be North Lakota and South Lakota, and I would have worked at UNL instead of UND. But the three cultural groups within the Oyate, or my people, is Lakota, Dakota, and Nakota, and very similar culturally, but slightly different dialects and some differences in cultural practices as well. So Grand Forks, the reason it's called Grand Forks is that it's the confluence of the Red Lake River heading west and the Red River heading north. And this was a gathering point for my people historically. And the Red River flows north into Lake Winnipeg. And of course, we did not draw the lines between US and Canada. Our people lived throughout this entire region. And same is true in North Carolina, that the tribes existed across what are now state lines. But historically, we just lived in large regions. But here in North Dakota, of course, we have an international border that we contend with. The Nakota people were renamed Assiniboine. So the Assiniboine River that goes into Winnipeg and meets the Red River heading north is basically the Nakota River. And this whole region was a gathering point for my ancestors historically. And I'm sure everyone knows the state Minnesota. A lot of people don't know where that word comes from. So Minnesota is actually two Dakota words. Mani means water, and Shota means cloudy or smoky. So we called this region with all the lakes Mani Shota Makoche, the land where the clouds rise off of the water. So very beautiful descriptive term, the land where the clouds rise off of the water. And now we just call it Minnesota. But it's interesting, most people out here don't realize that. And I'd really encourage you to look at some of the historical names of the towns where you're from and the regions where you are in North Carolina, because there is a strong and vibrant American Indian community right there in North Carolina. So when I think about some of the challenges that we're facing today, it's important to understand some of the history and where our population comes from, and what are some of the bases for the health challenges that we're facing, including cancer disparities and challenges with cancer control. And historically, we did not have a written language, so we don't have old history books or textbooks to draw from. We have an oral history, and we learn lessons about culture and lessons about life through stories. And in this region, there's a story of three sisters walking along a river. And as they're walking along the river, they see babies and young children in the water struggling to stay afloat. So the first sister declares this is an emergency. It's a crisis. We need to get the babies out of the water immediately. The second sister thinks about that and says, no, we need to teach the babies how to swim so they can survive while they are in the water. And the third sister keeps walking upstream, and the other two get angry with her and ask her, where are you going? Why aren't you helping us? And she says, I'm going to find out who's putting these babies in the water, and I'm going to stop them. So that literally is public health. That's literally working further upstream. So in the story, they don't use the terminology primary prevention, secondary prevention, and tertiary prevention. But essentially, that's the basis for that story. And when I think about cancer control in the American Indian population, or any population for that matter, we really do need all three of those levels of prevention, right? We need to address the crisis when it occurs. Certainly, if there is late stage cancer diagnosis that needs intervention immediately, we need that type of care. We also have survivorship and people who live with cancer, and we need to make sure that they can survive and live in a as healthful and fruitful way possible, even with a diagnosis of cancer. But then, of course, we need that third sister going further upstream and preventing cancer from occurring in the first place. So one of the challenges that we face here in the Northern Plains is very high rates of cigarette smoking and commercial tobacco use. And not surprisingly, we have very high rates of tobacco-related cancer disparities. And I know there's challenges related to that in North Carolina as well. So we see a lot of similar patterns. In some parts of the country, however, the American Indians' commercial tobacco smoking rate is actually very low, and we tend to see lower rates of cancer. So when we're thinking about cancer control in American Indians, we have to recognize that there's a great deal of diversity across the American Indian and Alaska Native populations. And there's not a single pattern of health disparities. There's a lot of regional differences. So we have to be cognizant of that as we're looking at principles of cancer control within American Indian populations. One of our biggest challenges as a population is historical loss and historical trauma. And we do know that traumatic events change the body's physiology, right? That the trauma response in many ways is a defense mechanism. And unfortunately, when we have unrelenting stress or chronic toxic stress, that can lead to all kinds of health disparities. And it can lead to also disparities related to self-medication to try to address the trauma. And it's important to be cognizant of the fact that the entire region of what is now the lower 48 states was Indian country, right? This is all territory of indigenous peoples. But based on colonization starting in the Northeast and then moving westward, many of the tribes no longer exist, unfortunately. And we have about 14 states in the US that have no tribes left at all, no more federally recognized tribes. So there's been a tremendous amount of loss over that period of time. And what does that mean for us as individuals and as populations? Well, historically, we had our own food systems. We had healthy foods. At one point, of course, all the food was organic. And we were able to hunt and gather and other types of agriculture, including farming. So we had healthier food choices historically. And then once our people lost access to their homelands and lost access to traditional food systems and were put on reservations, people became dependent on federal government food programs. And you may have heard of the Commodity Food Program. And within the United States Department of Agriculture, in the Commodity Food Program, there's what's called the Food Distribution Program on Indian Reservations, FDPIR, Food Distribution Program on Indian Reservations. And the quality of food has improved a lot over the last decade or so. But when that program was originally started, it was very unhealthy food. So when we think about diet-related cancer risk, a lot of that is policy mediated through the federal government. And our people were, again, taken from homelands, put into reservation communities, lost their food systems, and then became dependent on very unhealthy foods that were distributed by the federal government. So when we're thinking about cancer control in the American Indian populations, we have to be cognizant of the fact that there are policy bases for some of the disparities, including diet-related cancer risk. So thinking about this, and this is an area where I've been doing more of my research in recent years, is looking at intergenerational trauma as a basis for chronic disease disparities, including some forms of cancer. And we have to recognize that there really was attempts at genocide of American Indians here in the United States. And some of those tribes are no longer in existence because of colonization. And that leads to the whole idea of historical trauma. Also, you might be familiar with the boarding school system that was put into place in the United States. And when we look at British colonization and then subsequently colonies, whether it's in the US or Canada or Australia or New Zealand and other parts of the world, that was part of the colonization playbook, for lack of a better term, is that the people would be displaced, put into reservations or reserves, and then kids taken to boarding school, largely to get rid of the culture. That was the goal of the boarding school, was to assimilate and to essentially get rid of the American Indian culture. So we have a lot of stories, unfortunately, of abuse and neglect and a lot of mistreatment of the children who were taken to boarding schools, and the families were compelled to give up their children. I had mentioned we were dependent on federal government programs for food. So basically what the families were told once they were put on reservations is either give up your children or we will withhold your rations. So essentially give up your children or starve. And that was the way many children were just taken away to boarding schools. And this is not ancient history. My mother is a survivor of boarding schools. And that's just ubiquitous across Indian country. And the boarding school experiences for many people were unfortunately very harsh, and a lot of abuse and neglect associated with that. There's a picture of the Carlisle Indian School, the graveyard right next to the school in Carlisle, Pennsylvania. It's one of the more famous Indian boarding schools. And there's hundreds of boarding schools. Actually, if you're interested in learning more, in May of this year, Secretary Deb Haaland, for the Secretary of Interior, commissioned a study on the history and impact of boarding schools in the United States. So that is available online if you're interested in learning more about it. But what's really challenging and disturbing is that there are huge graveyards at most of these boarding schools, some that have unmarked graves. And we know that there were things like outbreaks of tuberculosis, but we don't know why there was so much excess death at the boarding schools among children. And we probably will never know why they were so deadly. Lots of children perished, unfortunately, when they were in the boarding schools. And then my question is, what about the survivors? If you're a child and you see so many of your friends and playmates and classmates dying at an unnaturally high rate, that has to have a negative impact on you psychologically and emotionally. This is a famous picture from Carlisle Indian School, and this is a class photo. And I have 4 children of my own, and I've seen lots of class pictures, and I usually see a lot of smiling and laughter and joy in a class photo. And I look at these faces, and I don't see any of that. So unfortunately, just entire generations of American Indian and Alaska Native children put into boarding schools, and unfortunately, a lot of terrible experiences within this. And it's a part of our history that's important to understand because there are intergenerational effects of this type of an experience. This is another famous picture. This is a Navajo young man. On the left, that's when he arrived at boarding school, and then 3 years later on the right. And this was kind of billed as a success story. It's like, look, he's no longer American Indian. We succeeded in basically taking the culture out of this human being. So this was really the purpose of the boarding schools, and it was ubiquitous. It just affected tribes all over the nation. This is a family, the Standing Bear family from South Dakota, where I am from. On the left, upon arriving at boarding school, then on the right, 3 years later. And again, this is seen as a success story because look, they're no longer American Indian. That was the goal, again, of the boarding schools. So here's a question. For the poll everywhere, epigenetics refers to the study of changes in the regulation of gene activity and expression that are not dependent on DNA sequence. So go ahead and, if you're poll everywhere, go ahead and put in your answers, true or false. Epigenetics refers to the study of the study of changes in the regulation of gene activity and expression. Right. You guys are doing very well, yes. So when we try to understand the intergenerational impact of these historically traumatic events, whether it's loss of land and marginalization, loss of food systems, or boarding schools, how is it that these toxic, stressful events can be passed from one generation to the next? Well, one of the things that we've observed in epigenetics and in studies of animal models, we know that toxic stress can actually change DNA, not necessarily the sequence of nucleotides, but different changes to DNA, including methylation and effect on the telomeres and histones. And in animal models, these changes to DNA can be passed from one generation to the next. So one of the studies that we're doing here in North Dakota is actually looking at boarding school survivors and looking at their patterns of epigenetics and seeing if there is a similar pattern of epigenetic changes in their adult children. And then we have control groups to look at this. So actually looking at what are the patterns of epigenetics. And in truth, cancer is epigenetic, right? That we might have some genetic predisposition, but there's some sort of external force that's changing the DNA to lead to cancerous changes. So we haven't hashed out all of the mechanisms, but I believe that epigenetics will provide the scientific platform to better understand intergenerational and historical trauma.
Recording stopped.
Oh, that sounded like the recording stopped, just FYI for the organizers. So we need to get that restarted. So just kind of going through that timeline then and thinking about after boarding schools and some of the other challenges. Oh, here, let's see. Do I need to restart the recording? So it says, please ask the host to restart the recording, just FYI.
Dr. Warne, I apologize. We did have somebody's bandwidth drop out, but we actually have an alternate method for recording, so the recording won't be interrupted.
Okay, sounds very good. Appreciate that.
Thank you.
All right. So I'm sure many of you are familiar with the Adverse Childhood Experiences Study, or the ACE study. And what the Adverse Childhood Experiences Study showed is that the more adversity someone faces in childhood, the worse their health status is as an adult. And unfortunately, in many of our American Indian populations, we have higher rates of exposure to adverse childhood experiences. So that intergenerational pattern of abuse and neglect, and again, from one generation to the next, and puts the entire population at greater risk for poor health outcomes. I had mentioned the FDPIR, that's the Food Distribution Program on Indian Reservations, historically a very unhealthy food, and was made improvements over the years. But historically, through the USDA, there was a lot of unhealthy food that was fed to the entire population of American Indians living on reservations. WIC program, Women, Infants, and Children, they've done a much better job in recent decades promoting breastfeeding. But when I was working as a full-time clinician back in the 90s and early 2000s, the WIC program on the reservation was basically a baby formula distribution center. And we know that as a population, formula-fed babies grow up to have higher rates of obesity than breastfed babies. And we know that there are some forms of cancer that are at greater risk when the individual is obese. So we have to look at this from a policy perspective, and the types of nutrition programs or food programs that are delivered by the federal government can put people at risk, greater risk for things like cancer and other chronic disparities. Kind of
Recording in progress.
Moving along and looking at ACEs or adverse childhood experiences. Again, the more adverse childhood experiences someone has, the worse the health status is during adulthood. So it's like a dose-response relationship. You know, the more ACEs, the worse the health outcomes. So we do also see higher rates of risk factors for things like cancer, like higher rates of smoking, higher rates of alcohol intake. But also life potential is impacted by adverse childhood experiences. So we see higher rates of poverty, higher rates of dropout, and other types of challenges, unfortunately. I'm very proud of at the CDC, the National Center for Injury Prevention has kind of revised the ACE pyramid. Historically, the pyramid had adverse childhood experiences at the base. But the National Center on Injury Prevention, we worked with them, and they recognize that historical trauma and the generational embodiment of historical trauma can lead to the social conditions in which people are at greater risk for adverse childhood experiences. So even the CDC is now recognizing the role for historical trauma in putting populations at greater risk for adverse childhood experiences. So again, just think about cancer control and the challenges related to working with populations that have dealt with significant trauma. This does have an impact on health-related behaviors. So the types of community engagement activities that might work very well in a suburb are not necessarily going to work effectively in a reservation community. We need to really understand the local social conditions and the history of the communities as we develop public health interventions and try to focus on things like primary prevention activities. So here's a good question. Adverse childhood experiences in the literature are associated with what type of cancer? Lung cancer, colon cancer, breast cancer, or all of the above? So adverse childhood experiences are associated with the risk of what type of cancer? All right, very good. Let's have a few other lung, good. Yep. Very good. All right. Well, what we see in the literature is a strong association between adverse childhood experiences and lung cancer. For colorectal cancer, we do see lower rates of screening. So those populations who deal with high ACE scores will have less colorectal cancer screening, and then by default, greater risk for more morbidity and mortality. But there's actually strong associations between lung cancer and adverse childhood experiences. And there's been some really good studies to look at this. So there's a prospective cohort study published in the Public Health Journal out of Great Britain, and showed that there's a strong association between adverse childhood experiences and lung cancer. And another study looked at this in terms of a systematic review, a meta-analysis of the data, and found that ACEs are an important risk factor for the development of lung diseases and lung cancer as adults. So the original ACE study was done in the Kaiser Permanente HMO population in California, and they had over 18,000 participants in the original ACE study. And what was valuable about that particular data set is that they had linkage to all of the health-related data for those individuals. So the addition of the ACE questionnaire was very powerful, because then they could draw these associations between health outcomes and ACE scores. But yes, for at least in the current literature, we see that strong association with lung cancer. I would not be surprised if we continue with these studies that we would see strong correlations to other types of cancers as well. So very good. Well, unfortunately, the challenges and the stressors do not end at age 18, right? We also have adverse adulthood experiences and toxic stress. And I know that in states like North Carolina, it's relatively diverse, right? You have a lot of different racial and ethnic populations in the state of North Carolina. In places like North Dakota and South Dakota, it's not very diverse. We have, in South Dakota, for example, about 12% of the population is American Indian. In North Dakota, about 8% is American Indian. And then there's less than 1% of other populations like Black or African American or Asian American or Pacific Islander. So the vast majority of the population in the Dakotas is white, so probably 85%. And unfortunately, there's a lot of racial tension still between American Indian populations and the white population in the Dakotas. And we see this, percolate. Just even last year, believe it or not, there was a hotel in Rapid City, South Dakota, that made a policy, no Native Americans allowed. Just made a policy, no Native Americans allowed. This is in 2021. So obviously that caused a huge uproar, and there was lawsuits and all kinds of things happening. But just the fact that that could happen today is remarkable. So when people are facing overt discrimination, and think of, racism as kind of an attitude, discrimination is an activity. There's actually discrimination, just really overt. A lot of our populations then are dealing with toxic stress. And we know that when people are living with toxic stress and all the stress hormones, it's not good for risk for chronic diseases. And then a lot of people are self-medicating their stress, whether it's alcohol, substance abuse, food, or commercial tobacco, cigarettes to deal with stress. I think we have to recognize that there is probably a direct correlation between stressors and some forms of cancer, but there's also a direct correlation between toxic stress and self-medication that can cause greater risk for cancer, things like cigarette smoking. So all kinds of challenges that we're facing. And the one thing we cannot do as healthcare systems is be judgmental of the populations that we're working with. And I still see that as well. And my colleagues in medicine, unfortunately, can say very discriminatory and racist things about the populations that they're working with, including American Indians, and being very judgmental, kind of blaming the population for having high-risk behaviors without really stopping to try to understand why those high-risk behaviors occur in the first place. So it gets very challenging when we think about cancer control in American Indian populations. It's not just about taking evidence-based health education practices about commercial tobacco and just plopping them into the reservation community. We actually have to really get immersed in community engagement and understand what are those local factors leading to higher rates of cancer and other chronic diseases, but also higher rates of risk factors for cancer. So we have to be cognizant of all of those things. So here's some data hot off the presses. We're in process of getting this published. Our cancer registry is always a few years behind in terms of being updated. I'm not sure how it is in North Carolina, but our cancer registry data is a few years old. But when we look at some of these numbers, it really is remarkable. Looking at lung cancer and colorectal cancer and oropharyngeal cancer, if we look at the rate for the American Indian Alaska Native population, let me pull that back. This is really remarkable. 119.9, basically 120 per 100,000 population, whereas for the white population, about 55. So the lung cancer rate for American Indians in North Dakota is more than double. Isn't that remarkable? Colorectal cancer rate is also higher, not quite as bad of a disparity, but still significantly higher rates of colorectal cancer. And one of our challenges is with lack of screening and lack of access to screening. We wind up diagnosing colorectal cancer at later stages, unfortunately. So all kinds of challenges that we're facing with cancer disparities. So again, the rate ratio for lung cancer, 2.16. Isn't that remarkable? So more than double the rate, and about 40% higher for colorectal cancer, still statistically significant. But that rate ratio for lung cancer for American Indians in North Dakota is just remarkable. I mean, among the worst disparities in the world when we look at American Indians in the Dakotas and lung cancer incidence. In addition, the lung cancer mortality rates are terrible because we also don't have equitable access to screening for things like lung cancer, right? That the screening procedures are wonderful for lung cancer now using low-dose CT, but how many low-dose CT scanners are available in the Indian Health Service? Well, zero, so we actually have the opportunity to do better screening because of the technology, but we don't have access to the technology. So again, just thinking about cancer control in American Indian populations, we can't assume that an evidence-based practice that's working effectively in a city or a suburb can be applied to a reservation community because we have inequitable access to screening technologies, unfortunately. So if we look at stage of lung cancer at time of diagnosis, I know this is kind of a busy slide, but for American Indians in North Dakota in the blue bars. Look at that, stage 3 and stage 4. Just remarkable disparities in terms of stage and diagnosis. So not only is the incidence higher, the stage at diagnosis is later. So not surprisingly, the mortality rate is also much worse, unfortunately. If we look at stage at colorectal cancer diagnosis, we're seeing stage 2, 3, and 4 much more prevalent than early stage. And the challenge here is we just don't have access to colonoscopy in most of our reservation communities. So, and I've worked with a lot of epidemiologists years, and they say, well, yeah, but a FIT test is just as effective as a colonoscopy or an FOBT. And I always say, yes, that's true, as long as you have a colonoscopy for the positive FITs, the positive FOBTs, right? We don't have that. We have people who are having the stool tests, the blood tests be positive. So we're having positive FIT, positive FOBT, and still no colonoscopy because we just don't have access to it. This is really remarkable and just terrible inequity and really a social justice issue. From my perspective, if you have a positive FIT and you're not doing a colonoscopy, that's criminal, but that's unfortunately the circumstances in which we're dealing with for American Indian cancer control. So I think, FIT tests, FOBT tests, those are wonderful technologies, but only effective if the positive results actually get into colonoscopy. And we have some preliminary studies and some preliminary data in terms of our health services research that the time between positive FIT or FOBT and actual colonoscopy, not surprisingly, much longer time in between those tests for American Indians. So again, our cancer control efforts are very complicated by the fact that Indian Health Service in most of the country is terribly underfunded, and we don't have access to some of the basic screening that we would expect to be available to most people in the United States. So this is looking at just stages of cancer for American Indian Alaska Native. So here's lung that's highlighted, and we can see that typically for stage 3 and 4, American Indian the population has much more common stage 3 and 4 diagnosis. You can see about 80% of lung cancer is diagnosed in stage 3 or 4. So just, again, different ways to look at the data, but very challenging. For the American Indian population, North Dakota, lung cancer trends, just much higher rates, and it's always statistically significantly higher incidence, but again, later stage of diagnosis and more mortality. Just as a side note, we're unfortunately in North Dakota, one of the state Medicaid programs that's not covering the lung cancer screening. We're working on that, and there's other states that are working on that, as you can see here on this map. But it's just remarkable to me that we have access to, we have a technology that's inequitably accessed and inequitably available. Therefore, we have disparities. So again, much of the cancer control challenges are also in the policy arena, right? That it doesn't have to be this way, but this is the circumstances which we're working. So just trying to think of, the healing from trauma and more holistic perspective. When I talk about trauma, if I was talking to emergency room physicians, they would think of physical trauma, right? Injuries. But we can experience trauma holistically, mental and emotional trauma, psychological trauma is much of what's been studied with adverse childhood experiences. But I would put forth that for Indigenous peoples, loss of language, loss of culture, loss of traditional practices, loss of sacred sites, that's a spiritual trauma. And if we think about healing from this, we're not going to fix this by prescribing medications, right? Where there's no pharmaceutical way to heal from this. It's going to require a much more holistic approach. So I would just put forth that whether it's in the cancer community or any medical arena, let's be more holistic and let's be accepting of the fact that some populations need more holistic interventions to create healthier circumstances in which people live, which can then ultimately lead to lower rates of all kinds of diseases, including cancer. But even the role for traditional culture and ceremony and prayer. There's some really good evidence on cognitive behavioral therapy and mindfulness and promoting healing in many people. Physical activity, obviously, is still very important in the physical arena. Then in the emotional arena, social connectedness is so vitally important. During the pandemic, I wish we had never used the term social distancing, right? 6 feet is a physical distance, not a social distance. And what we're seeing is that with social isolation and disconnection, we're having a significant challenge with mental health considerations now as well. So I'm sure many people have seen this image of equality and equity, right? Where we think of equality as everyone gets the same package of services. Everyone gets the same evidence-based practice. Everyone gets the same curriculum, whether or not it meets your needs. Everyone gets the same Medicaid plan, whether or not it meets your needs, right? So on the left, we can see that package of services. Maybe it's a cancer control program. For the guy on the left, he didn't need it. It's serving the one in the middle very well. The guy on the right is still underserved. So within equity, we're not just looking at the package of services, we're trying to look at the outcomes and what can we do to promote equitable outcomes across diverse populations. So I'd been showing this image for years, and a few years ago, someone sent me an image that I think is just brilliant. And the question is, what is that fence doing there in the first place, right? Is it just a package of services to overcome the barrier, or do we need to get rid of the systemic barrier? And I think part of our systemic barrier as Indigenous people, as American Indians, is just the lack of understanding of our history, lack of understanding of the impact of historical trauma in boarding schools on contemporary health challenges. And it really is a systemic barrier when our health systems don't understand these things. So I'd say it's up to all of us to really have a better understanding of our populations that we're working with. Just very briefly, with my new roles at Johns Hopkins, it's just started in September, so very new, but we're looking at developing an international Indigenous health database to try to better understand the correlations between boarding schools or residential schools and historical trauma and things like cancer disparities. And we're looking to do this internationally with Indigenous peoples. We also have an Indigenous Health DRPH. There does not yet exist a doctorate in public health with an Indigenous health specialization. So we're planning to do that, as well as expand our work in traditional medicine and looking at developing a documentary and a textbook on traditional medicine. All right, increasing education, cancer screening, and treatment access are all ways to promote equity in American Indian cancer control. So on your poll everywhere, is that true or false? So we're ending on what I would hope would be a very easy question, right? Obviously, increasing education, increasing screening, and access to treatment are what we need. So really thinking about those three sisters, right? Primary prevention, secondary prevention, and tertiary prevention. And we definitely need work across the board. So just some final considerations for cancer control. Let's make sure that we're including American Indians and Alaska Natives in our data sets. I used to be on the board of directors for the American Cancer Society. And when I started my role on the board more than a decade ago, they were still collecting data as, Black, white, Hispanic, and other. So we were, as Americans, just lumped into the other category. We can't do that anymore. If we want to promote equity, let's include American Indians in the data sets that we're working with. We also have to respect tribal data sovereignty, and that tribal nations are sovereign nations. And we should be collecting aggregated data for American Indians, but making sure that the tribes control their own data and understand their own patterns of health disparities. We need more American Indians, Alaska Natives in leadership positions and on boards of directors and in academic leadership. As it stands currently, there are 0 American Indian medical school deans. 0, not one in either the US or Canada. That's a problem. We need to have leadership development as when we're talking about addressing health equity for underserved populations. And basically, we just need equity across the board with prevention, screening, ideally early diagnosis and early intervention, better care coordination, better palliative care, and more education. And again, we need to decrease that time between things like a positive FIT or FOBT and an actual colonoscopy. That's the areas where we need to work. But not an easy task. It's going to take all of us to push this boulder up the hill. All right. I think I left a few minutes if there's any questions or comments, but that's my email address for anyone who wants to reach out. dwarne1@jh.edu. And I think I can stop.
Thank you so much. That was just a really fantastic presentation and a great overview of the historical and contemporary nature of American Indian health disparities in general, and definitely those striking disparities that exist currently in cancer incidence. So just thank you. Really appreciate that, and appreciate the history lesson too. In the beginning, we've had, even for SciCep, we had a good conversation with my co-leaders Stephanie Wheeler and Ronnie Bell about the name. What's culturally appropriate, and so thanks for that context. That was really helpful. Guess we will wait for Tim. Let us know if there are any questions from the audience. Just pop it in the chat, and then Tim can. Okay, all right. Waiting for questions. While we wait, I have one. It was really fascinating, the new area of research in epigenetics, and I think that can really help shed light on potential biological mechanisms. Do you know of studies that have looked at kind of tumor characteristics in American Indian cancer patients? Are those different or similar to what we would see in white patients or African American patients in terms of do they tend to be more aggressive? Do they tend to be of one subtype and things like that are becoming more and more relevant as we think about precision medicine and targeted therapies?
Yeah, and one of the things that we see, particularly with breast cancer, is that for both American Indian and African American populations, we're seeing it occur in younger populations, which is really disturbing. So younger populations tend to be more aggressive, and that hasn't been, at least what I've seen, hasn't been adequately studied and really understanding what are some of those mechanisms. But we do have some evidence that some forms of cancer are more aggressive and are occurring earlier. And for some reason in North Dakota, we have colorectal cancer occurring at a very early age as well. So earlier age of diagnosis and more aggressive forms for some types of cancer.
Yeah, great. Yeah, definitely lots of additional work to do to disentangle those social and biological drivers of American Indian cancer disparities. And so thank you so much for your work. I know we're at time, and if folks have questions. Oh, there was a question: how clinics classify race and ethnicity, and if creating more accurate measures that may better capture Central and South American populations. I guess that was going to your definition about, to your point about how those race is coded.
Yeah, it gets very complex, doesn't it? So, so for American Indian and Alaska Native, that's really self-reported. So technically, Native American is not seen as a race, as defined by OMB. And I don't know why its Office of Management and Budget had to characterize the races and ethnicities. But we do have Indigenous peoples from other parts of the world who are U.S. citizens, right? So how do we characterize those populations? And I think that a lot of that is still not yet completely resolved. And even thinking about the Hispanic population as an ethnicity, the Hispanic population is a blend of Indigenous and Spanish and Portuguese that came together. So there's really challenging issues related to this, and we have to be cognizant of it and think about how we're reflecting the data.
For sure. Thank you so much, and thank you everyone for joining. We appreciate your time here. Just a quick note that our next webinar is coming up February 1st, and we will be sharing this flyer. We have another fantastic presentation by Dr. Westcott in February. So thanks, Dr. Warne. Thanks to everyone, and hope you have a great rest of your week.